means backflow of blood in the pulmonary circulation, which results in less efficient gas exchange. Okay, they're also going to get essentially rheumatoid arthritis. That's what it means, acute onset of polyarthritis, and this would be an acute onset versus normal rheumatoid arthritis. What are arthralgias?
Joint pain.
Joint pain. And muscle weakness, because the pulmonary congestion, which means less blood is getting out to the muscles, which is going to cause weakness. You're definitely going to have a fever, and there's going to be heart palpitation. Okay, coronary artery disease has a few different causes. There can be a clot. We can have spasms of the arteries. We can have atherosclerosis of the arteries. Okay, so a thrombus is a clot that's moved from somewhere else or has the potential to be dislodged. So when you have enough plaque buildup, it can cause a thrombus. It's one big occlusion. And then, yeah, if it gets knocked loose, then it's an embolus. And then what's the other thing besides atherosclerosis that can happen to the arteries?
Arteriosclerosis.
Arteriosclerosis, which is the stenotic part. Okay, so all of these play a role in developing coronary artery disease. Genetics, environment, culture, nutrition, and should we capitalize smoking? Okay, symptoms are not going to appear unless the blockage is greater than 75%. So patients often go undiagnosed, which is dangerous. And what's going to happen if the coronary artery disease gets bad enough? Myocardial infarction. Now, what is the pain called when you either have temporary or permanent occlusion of the arteries? And it causes pain. Angina. Okay, so just like with stroke, you know, you can have a TIA. You can have that similar with coronary artery occlusion. So part of the heart vessels become temporarily occluded and maybe not completely occluded. You could get some angina, and then you decrease your activity level and it goes away. Kind of similar to a TIA in the brain. But it means they're at a huge risk of developing an actual MI. Okay, so myocardial infarction is a heart attack. It's when you have ischemia of the heart muscle because the coronary arteries become occluded. It's diagnosed by both an EKG and blood tests. We're going to talk a little bit more about this later, but the blood test, they are looking for creatine kinase. Creatine kinase is an enzyme that muscles release after they've been damaged. So technically after a hard workout, you also have increased levels of creatine kinase. The big one they're looking for is troponin, which is a protein that helps regulate muscle cell contraction. And it gradually starts to increase after you've had a heart attack. So if you've increased plasma levels of troponin, it indicates that you've had a heart attack. Okay, so signs and symptoms. It would be sudden, constant pain pain or pressure. It's not always described as pain, sometimes it's described as pressure. It can be anywhere in the upper quadrant. Neck, shoulder, arm, chest. The patient will have shortness of breath, excessive sweating, and unexplained fatigue. Okay, so any sudden onset of pain or pressure anywhere in our upper quadrant can indicate a heart attack. And then you say, okay, you're going to the ER, or you initiate emergency medical services. Okay, so this pain called angina pectoris, in the pec region, happens when the coronary arteries are unable to supply the myocardium with enough oxygen. Okay, we have 4 different types, and you have to know the difference between them. Okay, nocturnal most commonly occurs during congestive heart failure. And again, it would happen at night, and it usually would wake someone up from sleep. So nocturnal angina is most common in congestive heart failure. Occurs at night. This one I can't pronounce is usually because of coronary artery spasm. And it will not, just write this down and then I'll explain what it means, but it will not be relieved by nitroglycerin. And we'll talk about what nitroglycerin is later. Okay, stable angina in a way is the best kind you can have. It's where the pain only occurs at a predictable level of exertion. So you push the patient on the treadmill every time they are walking for 5 minutes at 2.5 miles per hour, they start to get angina. It means it's too intense, you need to lower the intensity of the activity. So to rehab them, you would do aerobic exercise below the level of exertion where the angina comes on. Predictable level of exertion. None of the others have that. Stable is the only one. Unstable means who knows when it's going to happen. It can happen at rest. It can happen with activity. It can vary in frequency and duration. They would be considered medically unstable if they have unstable angina. And really at risk for having a heart attack any second.
Not good.
You do not exercise someone with unstable angina. Stable angina, yes. Okay, this is what the inside of an artery with arterio and atherosclerosis looks like. It's very beautiful. All the white, the black, the cholesterol, triglycerides. Arrhythmias. Arrhythmias are a disturbance in the electrical activity of the heart. It can be a flutter, a fibrillation, or sometimes a heart block. So there's 3 different types of arrhythmias. And with coronary artery disease, if the arteries are affected enough, it can cause an arrhythmia. Arrhythmias are dangerous because they increase your likelihood of developing a thrombus, which can turn into an embolus. Does anyone know why a disturbance in the electrical activity would promote clot formation?
It's not being pushed through fast enough.
Not fast enough, but smooth enough.
Yeah.
So if the heart contractions aren't regular, they're irregular, it'll swoosh the blood around, and when blood is shaken, platelets like to aggregate. Versus if you just have smooth flow of the blood through the chambers, as is normal, the platelets won't try to hang out with each other. But if you start to have irregular contractions, you're essentially swooshing blood around, abnormal turbulence in the flow, which causes platelet aggregation. So that's why an arrhythmia is dangerous. One reason why. Okay, so we were saying before, a thrombus is where you have a clot form on the inside of the wall of an artery, and an embolus is when it gets knocked loose. So if we have a thrombus in one of our deep veins, like in the calf, and it gets knocked loose, where is it most likely to then lodge?
The lungs.
The lungs, and then you end up with a pulmonary
Embolism.
embolism. Okay, so when someone has coronary artery disease, when they're diagnosed with it, they are likely going to have surgery. And the first surgery, this is a picture of it. And let me find the page in your book. Okay, it's on page 225 of your book on the bottom, and it's called a balloon angioplasty. So they take a catheter, usually through your femoral artery, and then they go all the way up into the coronary arteries, and then they inflate a balloon to open up the artery wall. And sometimes that balloon has a metal cage over it, and they leave the metal cage there to hold the artery open. Okay, so balloon angioplasty is one medical procedure that someone might receive when they have coronary artery disease. The other one is a coronary artery bypass graft, or cabbage. And it's where they are going to circumvent the obstructed coronary artery using a graft. So they take either the saphenous vein or what's called the internal mammary artery, and they basically create another pathway for coronary circulation, because basically the coronary artery is too occluded to try to repair. So with a cabbage, it's almost always what they call open heart surgery. So they make an incision here and they crack open your sternum. And so then they open up to the heart and they cut away the pericardium. This is an example of them taking out the internal mammary artery, and then this is what it would look like if they take the saphenous vein. And I actually got these pictures from Mr. K, the doctor, surgical textbook. Because I wanted you to imagine, if you're treating this patient afterwards, look at all these crazy wounds and incisions that they have now. Okay, so they're going to have a sternum that's healing, a big incision on the chest that's healing, potentially a huge incision on the leg that's healing, and then another one somewhere else on the pec. And then you want to get them up and walk. Is their leg going to feel very good? Not at all. No. Okay, so we have to think, like, well, it's not just their heart we're trying to keep healthy, but look at all these areas where they now had a wound and some surgeon went in and was jamming things around. Okay, so don't forget about secondary wound sites. What's going to happen when this patient wants to, like, cough or sneeze?
Hold their chest.
So what do you teach them to do if they have to cough or sneeze?
Hold his chest.
They have to brace it. Are you going to do any upper extremity exercise?
Nah.
No. And actually, upper extremity exercise is contraindicated post any adverse cardiac event anyway, until about 8 or 12 weeks. We'll go through that. Okay, heart failure. Heart failure is officially diagnosed when the heart is unable to pump sufficient blood to the rest of the body. So it would have to be a cardiac output of less than 4 liters per minute at rest. Okay, so heart failure is diagnosed when the patient has a cardiac output of less than 4 liters per minute at rest.
How about normal?
5. 5 or more. Okay, so there's a few things that are going to happen with heart failure. We're also going to eventually differentiate between left-sided heart failure and right-sided heart failure. When someone has heart failure, their heart chambers are likely already enlarged. And it's basically, think of it as the heart got fatigued over time. The ventricular muscles are going to have decreased contractile ability. They have less ability to contract, therefore less stroke volume, heart rate goes up. And the biggest thing that's going to happen is blood backing up throughout all systems. Which means we can have pulmonary edema and systemic edema. Okay, so we have, like I said, we have left-sided heart failure and right-sided heart failure. There's some independent individual causes that can cause just right-sided heart failure, but what happens most often is you have left-sided heart failure first, and then it progresses into total heart failure, so both left and right. Okay, so this is why I said you have to draw the circulation, because now you have to be able to do it backwards. Okay, so we have the left ventricle, and it's been working really hard for a really long time, because this patient has hypertension, which means every time it tries to contract, it meets all this resistance. Because the artery is narrowed, it won't distend, and there's lots of plaque buildup. Okay, so there's all these resistance in the arteries of the body. So the left ventricle has to work really, really hard to try to pump blood out. And over time, it's going to start to fatigue, because it couldn't pump out enough blood against this resistance, so the stroke volume went down, so the body tried to compensate by increasing the heart rate. So now the heart's contracting even more often. And eventually it says, I've had enough. Can't contract as well, it can't keep up, the cardiac output now goes down, and now it's less than 4 liters per minute, and now you have heart failure. Okay, so if my left ventricle over time can't eject all of its blood, blood is going to start backing up. And where is it going to back up to? The left atrium. Now the left atrium can't eject all of its blood because the left ventricle is still full. So where is it going to back up to? The lungs. And now we have pulmonary edema. Okay, aka pulmonary congestion. Okay, so signs and symptoms of pulmonary edema: shortness of breath, orthopnea, because what's going to happen when they lie supine? All that fluid is going to weigh down on them, and it's going to be even harder to breathe. They may end up with nocturnal dyspnea. So you stop breathing in your sleep and it wakes you up. They're going to have a cough, and they could potentially have spasms of their bronchioles. Okay, so all these are specific signs and symptoms of just pulmonary edema. But we also know that there wasn't much blood getting out to the body. So what are signs and symptoms of a low cardiac output? Fatigue, muscle weakness, cyanosis, and remember tachycardia because the heart rate increased to try to compensate for the decrease in stroke volume. Okay, so see how I'm not just listing symptoms, I'm saying, okay, let's go through logically, see what happened. If this happens, what are we going to see signs and symptom-wise? Okay, so left-sided heart failure, you're going to see the signs and symptoms of a low cardiac output to the body, and you're going to see signs and symptoms of pulmonary edema, because that blood flow backed up into the lungs. Now the heart failure is going to get worse, and from the lungs, where is it going to back up into? The right ventricle, and now the right ventricle can't empty. Where is it going to back up into? Right aorta, right atrium. Now the right atrium can't eject all of its blood. Where is it going to back up into?
Into the carcinoma.
The body. So signs and symptoms of right-sided heart failure are systemic. And we're going to have peripheral edema. And this is going to be edema all over the body. Okay, so we're going to see edema down in the legs. And it's going to be pitting. We're also going to see jugular vein distension. Remember, it's backing up into the venous system. We're also going to see what's called ascites, which is fluid buildup in the abdominal cavity. So a patient may think they just gained weight, but it's a sign and symptom of heart failure. So ascites is fluid buildup in the abdominal cavity. Okay, and they're still going to have some of the signs and symptoms of a low cardiac output. Okay, so the fatigue, the cyanosis, they're still going to have that. Those are common in both. Okay, but see the main difference here is the systemic congestion, the peripheral edema with right-sided heart failure, and the pulmonary edema with left-sided heart failure. Just think about circulation going backwards.